Okay, we'll get started. I'm Dr. Srihari Naidu, and I have Dr. Hima Vidula here with the governors for New York American College of Cardiology. I want to thank everybody for coming. As you know, that we do these webinars, we typically package them up, edit them, and then put them on the web. So we will hopefully get a lot of viewers over time. Today, this lecture for the next hour, which is valued at 1 CME credit. So please make sure you put that in at the end of the session. When you get your email link, you answer some questions and get that CME credit. It's my honor to introduce Dr. Quinn Capers tonight. This is on behalf of the Reiss-Odenheimer Lecture of the Diversity, Equity, and Inclusion Committee of the New York Cardiological Society and the New York chapter of the American College of Cardiology. Dr. Capers, I've only gotten to know relatively recently. I'd heard his name, and I was recently benefited from hearing him lecture at one of the meetings I was at a couple of weeks ago. He has an illustrious career. He went to Howard University and then went to Ohio State Medical School. He did his fellowship at Emory with some of my really dear friends, Dr. Jeffrey Marshall, who were just talking about that. And since then, he's really done a lot in the areas of diversity, equity, inclusion, recognition of bias. And as you know, in cardiology, these are at the forefront right now as we try to develop a workforce that's representative and allows us to provide really high quality care in a very balanced and fair way, which is, I think, the next hurdle in our society. He was also dean of the medical school back at his alma mater at Ohio State, and he made a lot of changes there in terms of representation while maintaining scholastic aptitude of the inducted classes. And from there, recently, he's taken over the role of vice chair of diversity, equity, inclusion in the internal medicine department, and also a dean in the medical school at UT Southwestern. So the format for this evening will be, he will be giving us a nice lecture about this, how it affects cardiology, and we'll have some question and answer at the end. If you do have some questions, please feel free to use the chat room and put them there, and Dr. Vidula and I will spend time trying to answer as many of these as possible. Dr. Capers, our pleasure.
Well, thank you so very much. It really is an honor to be with you, to be giving this Reiss-Odenheimer lecture. I'm humbled by your introduction, and I'm humbled by this invitation. So we have a lot of interesting things to talk about, I think. And so I really value the Q&A that comes at the end. So let's get right to it. And what we entitled this lecture is, you know, everyone says that we need to increase diversity in cardiology, but why? And that's important. It's important for you to have answers to that question, why? And equally as important are answers to the question, how? How do we do that? So here's where we're starting. And this is no surprise to you if you're a cardiologist. According to the latest US Census report, 51% of Americans are women, yet only 13% of cardiologists are women. 17% of Americans identify as Hispanic, yet only 5% of cardiologists are Hispanic, and 13% identify as Black or African American. Not even 3% of cardiologists are Black or African American. Everyone, and when I say everyone, I mean everyone, recognizes this as a problem. So all of these wonderful organizations, including our wonderful organization, the ACC, the Association of Black Cardiologists, has been at it for more than half a century, SCI, Heart Failure Society, NASP, the American Heart Association. We have a consensus on the fact that we need to increase diversity in the cardiology workforce. But why? Why? We want to delve into that a little bit. And then after why, we want to talk about how. So why? There is evidence supporting the need to enhance diversity in medicine and cardiology. And what I will show you is that there is evidence supporting the fact that physicians who train in diverse environments rate themselves as more comfortable treating minority patients. So there's an educational benefit to training in a diverse environment, because minority physicians are more likely to serve the underserved and disadvantaged. Minority patients are more likely to follow the recommendations of minority physicians. More minority physician scientists, we are convinced, will help to diversify clinical trials, and the lack of diversity in clinical trials is a big problem that we struggle with. Diversity in medicine will help us reduce racial healthcare disparities in all of medicine, and particularly in cardiology. Data shows, which I'll share some with you, that if we have diversity on our research teams, that the questions that we ask are more innovative and the research is more impactful. There is actually a relationship between diversity on the group of people doing the research project and the impact of the research. And we'll go over some of that. Let's start here. Physicians who train in diverse environments are more culturally competent. Saha and colleagues in 2008 published this study where they surveyed fourth-year medical students just about to graduate, just about to become doctors. And they asked them several things, one of which was how comfortable they were treating patients who belong to a race or ethnicity other than their own. They also noted the diversity in the student body at those medical schools and rated them according to quintiles. And they found a relationship that the more diverse the medical school, the more comfortable that doctor in treating patients of a different race or ethnicity. In the comments, they said that in this cohort of more than 20,000 graduating medical students, white students, so the real outcome was looking at this in white students who attended more diverse schools rated themselves as better prepared and more comfortable treating minority patients than did white students who attended less diverse schools. So there is a training effect that when you and I train with colleagues from a different culture, a different race, a different ethnicity, we learn a little bit about them. And in so doing, training shoulder to shoulder with them, we do a better job at taking care of diverse patients. How about this one? Underrepresented minority physicians are more likely to serve the underserved. When I made this slide, I had a goal that I fell short of. My goal was I wanted to find every study ever published on PubMed that shows that Hispanic, Black, Native American physicians are more likely than other physicians to choose to practice in underserved, disadvantaged, and vulnerable communities than our other doctors. But the slide wasn't big enough. So you'll have to settle for 10 studies from 4 different decades that remarkably show the same thing, that doctors from underrepresented minority backgrounds are more likely than doctors from other backgrounds to choose to provide charity care and to serve underserved and disadvantaged populations. It's no longer even up for debate. This is one of the few areas in medicine where the jury is in. How about this one? C, minority patients are more likely to follow the recommendations of minority physicians. And we have some evidence that that is true. This is a very interesting study done in Oakland, California by Alsan and group. And what they did when they randomized Black male patients to being seen by either a Black male doctor, a white male doctor, or an Asian male doctor, they saw a relationship between whether or not those patients were willing to have certain procedures done. Here's how the study was set up. All of the patients were Black males. They were randomized to having either a Black, white, or an Asian physician. The physician walks in and they all said the same thing, that this is what's available for you today. Blood pressure measurement, BMI measurement, blood glucose measurement by finger stick, cholesterol measurement by finger stick, and a flu shot. And we recommend that you have all of those. What they found, the findings were that those Black men were more likely to have their blood glucose checked, their blood cholesterol checked, and to receive a flu shot if it was recommended by a Black as opposed to a white or Asian physician. On that same vein, here's another study, again by Dr. Saha, who really has been brilliant in this space, giving us a lot of data that we can hang our hat on. In this study, they had actors play the role of what you and I do, cardiologists, actors playing the role of cardiologists. We call them standardized doctors as opposed to standardized patients. As you can see, you see there the photos that some of these actors were men, some were women, some were Black, some were white, but they all read an identical script. And in the script, they said, "I've reviewed your studies, I've reviewed the results, and I recommend that you have open heart surgery." Now, the viewers of the videos were actual heart patients. So they actually collected heart patients to have them look at these videos. Each patient saw only one video. But the outcome of the study, the main finding, was that Black patients were more likely to agree to open heart surgery if recommended by a Black versus a white physician. So that means if you're counting, if you put these two studies together, that means if we had more Black doctors or more doctors of color, more Black patients would get their blood glucose checked, would get their blood cholesterol checked, would get their flu shots, not to mention COVID vaccine, and would have open heart surgery when recommended. So it's not hard to make the argument that more diversity in medicine will improve the healthcare of all populations. How about this one? More minority physician scientists will help drive diversity in our clinical trials. You know, we've got a big problem there, and the FDA, the Food and Drug Administration, recognizes this. In 2016, the FDA declared 2016 the year of diversity. And they said, within our power, as much as we're able to, we no longer want to approve drugs or devices if the study that showed they are efficacious did not have a diverse population. That was the goal. So let me share with you some drugs and devices that have been approved since 2016, the year of diversity. Some of you likely have been able to use the new heart failure drug, ivabradine. The trial upon which its FDA approval was based had only 1% Black patients, 8% Asian patients, and not even enough Hispanic patients to cause any rating on this graph. Entresto, which I assume many of you are using, wonderful drug, a game changer in heart failure. The trial that showed that it works had only 5% Black patients, and again, not even enough Hispanics to equal 1%. Cangrelor, blood thinner used in the cath lab, again, it was approved based on a trial that had only 3% Black patients, 3% Asian patients. And TAVR, this wonderful new tool that we have where we can repair your aortic valve and you can go home the next day with a Band-Aid on your groin. The trials that show that TAVR is effective, 2% Black patients, 0% Hispanic patients. And this has been since the year of diversity, or so proclaimed by the FDA. Many who study this say that if we had more diversity amongst principal investigators, amongst the physician scientists, and amongst the research coordinators, the people who actually go to the patient's bedside and ask them, would you like to participate in this study? We have more diversity in those groups and more cultural competence in those groups, we would do a lot better about diversifying these trials. And so we do think that we can diversify clinical trials if we have more diversity amongst our principal investigators. How about this one? That diversity in medicine should help reduce racial healthcare disparities. They are still among us, especially in cardiology. Those are the ones that we pay the most attention to for obvious reasons. So let's go on rounds. Let's make some rounds at the hospital. Let's start out in the CCU, where we have these two patients here with severe congestive heart failure, refractory to medicine, and a poor ejection fraction, less than 35%. Well, right away, you and I know that if you have a poor ejection fraction and heart failure that is refractory to maximal medical therapy, you're at risk for sudden cardiac death. And the ACC-AHA guidelines tell us that you are eligible to receive and should at least have a conversation about receiving a defibrillator. So you and I are making rounds. We're in the CCU. These are our patients. They have an identical clinical scenario. So who gets the AICD? I'm sure in your mind, you're saying, why, of course, both. But that's not what the data shows us. The data shows us that this white male will be significantly more likely than the black female to get a defibrillator, despite having the same diagnosis and severity of disease. So we're still making rounds. Now our beeper's going off. We're being paged to the emergency department. So let's go down to the emergency department. And down there are two patients having a heart attack. They're suffering from an acute coronary syndrome, one a white male, one a black male. And what we know in interventional cardiology, and have known for a long time, is that an early invasive strategy, meaning the sooner we get you to the cath lab, do an angiogram, find the blockage, open the blockage, and restore blood flow, the more heart muscle we salvage, the more likely we are to save your life or prevent a much larger heart attack. So here are our two patients. Who gets timely cardiac intervention? I'm sure in your mind you're saying, well, of course, both. But that's not what the data shows. The data shows that the white male is much more likely than the black male to get timely, rapid cardiac intervention for their acute coronary syndrome. And we're talking about national data when you average what's happening nationally. Okay, we're in the emergency room. Now, you know what it's like when you're in the ED. Sometimes you can't get out of the ED because you keep getting tapped on the shoulder. Somebody tapped us on the shoulder and says, please come back here in this corner where we have two patients who showed up with a pulseless and purple foot and severe pain. And so we go and see two patients with critical lower extremity ischemia. And then the question is, who gets referred to the radiology suite or the cath lab or the vascular OR to have an angiogram, to find the blockages, get balloon angioplasty, laser, stenting, atherectomy, or bypass surgery, and restore blood flow to the legs, versus who gets an amputation? So that's your question. These are your patients, doctor. Who gets an angiogram? Who gets an amputation? And I'm pretty sure in your mind, you're saying, well, they both should get the very best thing available. And I appreciate you saying that, but that's not what the data shows. The data shows that when controlled for the extent and severity of disease at presentation, the white man is more likely to have revascularization. The black man is more likely to have an amputation. Again, this is looking at national data. And this data is not new. In fact, when we reviewed it a few years ago, we saw a few things. We saw suggested in this review paper that in a 20-year period, there had been 300 papers like the ones I just showed you, documenting racial disparities just in cardiology and cardiovascular care. 300 papers in a 20-year period. And the very sobering thing we noted is that things were no better at the end of that 20-year period and documenting the problem 300 times than they were at the beginning of that period. So you and I, we keep documenting the problem and documenting the problem, but it's not getting any better. There are many who believe, and you can count me in this number, that this naggingly persistent racial healthcare disparity in cardiology is parallel to the naggingly persistent lack of diversity in cardiology, and that we won't truly make a dent in it, truly move the needle, until we start to diversify the cardiology physician workforce. We got one more. And what I'm trying to do is give you data to use when you get some pushback about trying to enhance diversity in cardiology. There is evidence, as I told you, that diversity on the research team can impact the quality of the research. Alshabli and colleagues in 2018 published this in Nature Communication, fantastic study where, talk about being busy, they looked at 9 million papers, 9 million papers. They were looking to see if there is a correlation between diversity of the research team and impact of the paper. And they defined impact as the number of times the research paper was cited. What they found is that several types of diversity correlated with impact, but the strongest was racial and ethnic diversity. In other words, if you spend a large proportion of your time doing research, you want your research to have high impact, to be cited widely, then you want to have some diversity on your research team. So you and I now know, we've gone over the reasons why we should enhance diversity in medicine and cardiology. But if you spend a lot of time talking about this, like I do, you will get some pushback. I'm going to give you some examples of some of that pushback, but at least now you're armed to push back against the pushback. So pushback. So here's some. So here are some results from a survey research paper done by the Society of Thoracic Surgeons. So our cardiothoracic surgery colleagues received a survey from the STS that was asking them, how do they feel about the fact that cardiothoracic surgery is not a very diverse specialty? And as usual with these kinds of surveys, the real gold, the real juicy answers you get are from that last question on the survey when you ask, tell us whatever you want to about this topic. And here are some examples of responses. One person said, white males are currently being discriminated against in admission to college, med school, and residency programs. Cardiothoracic surgery should be a meritocracy. Another person said, I do not believe barriers exist. This myth of the necessity of diversity and inclusiveness is political correctness on steroids. We need to worry about turning out well-trained residents. Another person said the STS doesn't need to address diversity. And in fact, this shouldn't even be on the radar of things to be done. And finally, somebody said, what barriers? There are no barriers. None of the above are important. So this is what we talk about when we talk about pushback. But hold on now, we're not just gonna pick on our cardiothoracic surgery colleagues. They're not the only ones with pushback. If you were anywhere on social media or the internet the last year and a half, you probably heard of what was now referred to as the Wang paper, a paper by Professor of Cardiology, Dr. Wang, published in a very good journal, the Journal of the American Heart Association. You look at the title, it looks like it is another pro-diversity paper, but it actually was an argument against attempts to enhance diversity in cardiology. Several nuggets or gems in this paper, again, that was published. This isn't an abstract, this is a publication. One of the things that the author said was he conceded that there is a lack of representative diversity in terms of Hispanics, Blacks, and Native Americans in medicine and cardiology. But he made the case and implied that, you know, there's a simple answer for that, is because they're not qualified. Another nugget that came out of this was he conceded that Hispanic, Black, and Native American physicians do tend to, in greater proportions, serve underserved and disadvantaged communities than doctors of other backgrounds. But he implied that, well, the reason for that is, you know, they didn't pass their board exams. And as you and I know, if you don't pass your board exams, then you don't get to practice in a nice, big, shiny hospital downtown. You got to practice somewhere out in a rural, underserved area, and your job opportunities are restricted. As you can imagine, this was very harmful. I heard from a lot of trainees, a lot of medical students, pre-med students, a lot of people applying to cardiology fellowship. They wondered, is this how cardiology sees us? We had to do a lot of damage control. And so anybody who knows me knows that shortly after reading this, I was clicking my pen and writing, beginning to write with a group of other like-minded cardiologists a rebuttal. We contacted the editor and pointed out some inconsistencies and some untruths in this paper, and it did wind up that the Journal of the American Heart Association retracted the article. Now, I'll tell you something that I found out in this process, and maybe you already know this, so maybe you'll be like, well, gee, Quinn, everybody knows that. I used to think that when a paper was retracted, that meant that it was just scrubbed clean from the universe, that you can't find it anymore. But I was told by the editors of JAHA that no, it's still there. And in fact, this paper, it's still there. You can still find it on PubMed. You can still click the link and go to the website and download and read the entire paper, but the words retracted are written lightly across each page. So it's still there. So we did write a rebuttal with a group of colleagues. And the first attempt, they said, well, it's Quinn, it's too, your tone is a little too angry. Got to tone it down some. This is an academic paper. Your tone is not appropriate. Okay. We toned it down. And we sent it in again, and they said, well, your tone is still you still sound a little angry. You got to tone it down a little bit more. And they didn't want us to mention this paper at all. So where we started out with a rebuttal, they said, no, just don't mention it at all. And so on the third attempt, they took it. And now, because they didn't want us to mention the Wang paper, it now is simply a standalone document, evidence-based, research-based, showing why, in fact, we do need to enhance diversity in cardiology. But I wanted to take time to show you these two to show you that if you go around talking about the need to enhance diversity, you will get some pushback, and that's okay. How do we push back against the pushback? How do we do that? The way we do that is with evidence, with cold, hard facts and evidence, not with passion. We don't need to scream, we don't need to jump up and down, but with evidence, because there's plenty of evidence out there already, but we all need to be about the business of coming up with even more evidence. So why aren't we there yet? We've answered the why we need to enhance diversity. So why aren't we there yet? Because this is not new. The AMA, the AAMC, the National Academy of Medicine have been saying for years that we need to enhance medicine. So it seems that there is not a lack, urgency. Where is the urgency? Where's the feeling that this is an emergent situation? It should be handled like a STEMI alert. I want to remind you of something. I want to take you back just a little bit, more than a year ago now. And I want you to remember, if you would, how you felt the very first time. Maybe you've seen it more than once, but the very first time you saw that cell phone video footage of George Floyd being brutally murdered. I want you to feel that. Remember that? Remember that feeling that you had when you saw that? I want you to conjure that up again. And I want you to feel that. And I'm going to bet a few things with you. I bet that some of you were quite distraught. I mean, distraught. I'm going to bet that some of you might have even shed some tears. And I'm going to bet that some of you demonstrated and took a stand. And you said, and you made a pledge, and you said, I am going to do something. Or at your organization said, we are going to do something that we can do. We're doctors, so we're going to do what doctors can do. We're going to fight bias. We're going to fight racism. And that's the feeling I want you to have right now. This is your check-in. So how's it going? For those of you who work in academic medicine, you know that, for instance, I work in academic medicine. That means once a year I sit down with my cardiology chief and I get reminded of, these are the things at the beginning of the year you said you're going to achieve. How's it going? So this is your check-in. How's it going? You said you were going to pledge to fight racism, to fight bias. It's been almost 2 years. So I think we can say, and I hope you agree with me, that we have won this debate, and it is resolved that to enhance the quality of cardiovascular care and science, and to reduce persistent racial healthcare disparities, we must diversify the cardiology workforce. So we've answered the why. Now, what about the how? How do we do that? It's not It's not as clear because we've been trying to do this for 50 years or more. But if we all agree on taking the same steps, we all work in concert, we can finally move this needle. Step one is we've got to focus on the pipeline, because in our current situation, we have several problems. One is our selection processes can be biased, but equally as daunting as that problem is that those underrepresented minority groups are in very short supply all along the pipeline. And so we have to work simultaneously on what I call the end game, the selection processes, but also on beefing up that pipeline. I bet this is the best picture you're going to see all day. The cutest picture you're going to see all day. At the Ohio State University, our medical center collaborated with Columbus, Ohio City Schools to create a K-12 health sciences academy. These children are at their white coat ceremony. Isn't that cute? And they're going to have health sciences introduced into their curriculum from kindergarten all the way through the 12th grade. And of course, the ulterior motive is that we're going to make some doctors here. In addition to the curriculum, monthly, they are going to interact with real live doctors, pharmacists, dentists, nurses, physical therapists, etc. This is an important initiative. Now, this is a big deal. I'm not saying that every single institution needs to do this, but this is an example. And there are other shining examples of things that can be done. I want to show you something else that I like to call growing your own garden, something that we all need to be doing. We all can individually reach out. Look to your far left. These are fourth graders at what we call at Ohio State University, a program that we would do called Heart School. But we would have fourth graders come in on a Saturday and dissect cattle hearts proctored by our cardiology fellows and medical students. Here they're showing you their certificates that they've graduated from Heart School. We hope we're planting a seed. Take a look at that young man there. That's him as a fourth grader. That's him as a college pre-med student at Northwestern University. I was at Northwestern giving a talk and he popped down to see me, but we certainly had stayed in touch. And that's him as a second-year medical student in my clinic at the Ohio State University, one of my last clinics before leaving Ohio State to come to University of Texas Southwestern. So from fourth grade to medical school, we mentored this young man. And I like to say, somewhat jokingly, that I'm not sure how many more fourth grade to medical school cycles I have left in me, but this is what we all need to be doing. When was the last time you sat down with a third grader or a fourth grader and said, I think you can be a doctor, and I think you'd be a good doctor? And I'm not talking about your own third grader or your own fourth grader. I'm sure you do that with them all the time. But I'm talking about a fourth grader that's not yours. This is something that we can all do. Speaking of the pipeline, as you know, we're all still very proud of this initiative that we're going to need your help with, and that is our internal medicine resident pipeline program. So we are reaching out, the American College of Cardiology, to internal medicine residents around the country who are in underrepresented in cardiology groups. We started with Black internal medicine residents. Up next will be women internal medicine residents. Our third cohort will be Hispanic internal medicine residents. And then our fourth cohort will be a conglomerate of anyone who thinks they're in a group that is underrepresented in cardiology. So this, we imagine, is going to be people who might have some physical disabilities, our brothers and sisters in the LGBTQ+ community, people of any race who come from a socioeconomically disadvantaged background. Each of these cohorts will receive mentoring by ACC members, and we'll be counting on you for your help, New York ACC. And we're going to mentor these young people to cardiology fellowship. That is our hope. On that call of our first program, we had over 80 Black internal medicine residents from around the country. They heard about our specialty, They heard a panel discussion about private practice versus academics, and they heard a panel discussion of cardiology fellowship program directors. They're now each going to be hooked up with an ACC mentor. And we're going to have programs at least twice a year to check in with them and make sure they're on track to be applying to cardiology fellowship. This was a very, very special day. We meant for it to be in person, but because of the pandemic, we did it via Zoom. But we just really get inspired by looking at this picture. But this is pipeline work. Got to do pipeline work. Number two, it's time to leverage social media. You and I need to be visible as role models. And that is not only everywhere that you and I can be in person, but a lot of the people we want to attract to cardiology are on social media. They're on Twitter, they're on Instagram, they're on Facebook. And I have established a Twitter presence that I use mostly for recruiting and for speaking out against injustice. But I can tell you, as a medical school admissions dean, I would often hear from students applying, hey, you know, I like what you're saying on Twitter. As an interventional cardiology fellowship program director, which I was for a few years, I would often hear from applicants, I found out about your program by following your Twitter. So we want you to get on Twitter or Facebook or Instagram, you choose, but you can multiply yourself and reach out and inspire people. We started this campaign on Twitter, #BlackMenInMedicine, to try our best to counter negative stereotypes about Black men and the lack of Black men in medicine and cardiology. So we thought if we flood social media with images of Black male physicians, we will inspire young people. We will change the nation's unconscious negative bias about Black men, such that it won't be Black man automatically makes you think danger, but maybe we can change that to Black man, he just might be a physician. So we want you to get on Twitter, tweet out something under this #BlackMenInMedicine. You don't have to be Black, you don't have to be a man, you don't have to be in medicine. Just tweet out something that will inspire people to go into medicine. Step 3, you've got to recruit with a purpose, recruit actively. I've been coast to coast talking to program directors and cardiology practices. And very often what I hear is that there is a lackluster attitude about recruiting. Very prestigious cardiology fellowship programs will say, recruiting? Why do we need to recruit? They know who we are. We're listed in ERAS. They can find us. We don't need to recruit. We've got more applicants than we know what to do with now. But if you're serious about diversity, you have to actively recruit for diversity. This is one of my favorite pictures. I want to tell you that when I was Dean of Admissions at The Ohio State University, around 2013, we realized that in our medical school's 100-year history, not one time had we fielded a class of at least 50% women. We found that to be a problem. We treated it like an emergency, like a STEMI alert. So we asked a task force to study that and to come up with some recommendations. Are we doing something that's turning women away from the Ohio State University College of Medicine? They came up with some recommendations after speaking to women who had turned down our offer of admission, speaking to women who were matriculating, and they gave us some guidelines that we put into play. And since that time, now 9 years in a row, slightly more than half of the class have been women. And this picture is one of my favorites because this is me making rounds on the acute coronary syndrome service. And this is my team, all 4 doctors, all 4 that I had admitted to medical school. This is one of the joys of being a medical school admissions dean for a long time. At a certain point, you get to work with doctors that you admitted to medical school. So that means these ladies, I read their personal statement when they were applying to medical school. I was there on their interview day. I was in the room when we were discussing them. I saw them as first-year medical students conquer gross anatomy. And now here I was taking care of heart attack patients with them shoulder to shoulder. This picture really means a lot to me, and I think you could tell why. But the example is one of strategic recruiting. Where are the holes in your diversity? That's where you need to put your focus, and you need to be systematic about it. Step 4, be courageous about confronting bias. we had our entire medical school admissions committee, which at The Ohio State University is very large, 140 people. We have 140 people on the admissions committee. We had them each take these computer-based implicit association tests. Here's what we found. We found that half or more, so the majority of our medical school admissions committee, remember who this is. This is the group that decides who gets to be a doctor and who doesn't. This group, we found that more than 50% of this group had an unconscious bias where when they look at a man, the automatic association is he is a career person. And when they look at a woman, the automatic association is that she is a homemaker. We also found that more than half had an unconscious negative bias about members of the LGBTQ+ community. The third finding was that more than half of the committee had what we call an unconscious white race preference, which is when I look at a white person's face, my automatic association is with good things like family, joy, love. And when I look at a Black person's face, my automatic unconscious association is with negative things like pain, fear, violence, danger, misery. More than half. So what I just shared with you is what some consider the negative part of this research, but there is a very positive part, and that is once we review these results with the admissions committee at our annual admissions committee retreat, and then went immediately into an implicit bias mitigation workshop. The very next class we admitted was the most diverse class in the history of the Ohio State University College of Medicine. So we all have biases, but we can overcome and override those biases with some simple techniques. So we made implicit bias mitigation training an annual requirement of the medical school admissions committee. We made that recommendation for residency and fellowship selection committees and for faculty search committees. One of the things that we did was we put together an implicit bias mitigation cheat sheet, if you will. That is this laminated piece of paper that has on it written out some research proven strategies for mitigating our implicit biases in a one-on-one interaction. So on interview day, this is a faculty member that has with him not only the credentials of the person he's about to interview, but this implicit bias reduction cheat sheet. Here we are giving an implicit bias case-based workshop to the ACC's Board of Trustees. As you just heard, we just did something similar with the SCI Board of Trustees. Not all bias is implicit. Some of it is conscious and known and explicit. And so we've started something called bias and equity teaching rounds, where we get together just like a quarterly morbidity and mortality conference. We get together the care teams in the hospital and we review incidents of either racial insensitivity towards patients or their family members, or incidents in which someone thinks that the recommendations for the patient, that the treatment of the patient were negatively impacted by the patient's race. We discuss those, not to shame anybody, not to ridicule anybody, but to learn and to hopefully have fewer of these incidents as time goes by. We hope that this spreads throughout our medical center. We're already doing it here at UT Southwestern in the Department of Surgery, the Department of Internal Medicine. We'd like it to spread throughout UT Southwestern and around the country. Step 5, what if we made diversity / the ability to enhance the cultural competency of the program, what if we made that a top priority when we made our rank list? What would that look like? When we make that rank list, when we go into that room, and that's what this picture represents, when we go into that room and close the door, what I like to call the cigar smoke-filled back room, and make those decisions, I've got a question for you. At your institution, who's in the room? We did a survey of cardiology fellowship program directors, and we asked that question, who is in the room? And a proportion that's not insignificant said that there are no women in the room. There was another significant proportion, maybe 20%, that said there were no underrepresented minorities in the room. And there were about 10% of programs that said both were absent. So there are no women and no underrepresented minorities in the room. So it really did look like this picture, maybe minus the cigar smoke. So who's in the room when you're making those decisions? And what would it look like if you made diversity or the cultural competency of the program a top priority when making the rank list? Well, that's exactly what we did for the few years that I was the Interventional Cardiology Fellowship Program Director at The Ohio State University. And this is still an intact strategy that we use. What I'm showing you here is the actual sheets that we used when we interviewed our candidates. It was a point score system, along with a point score system for research, for collegiality, for teamwork, and for clinical skills. But in this category, we actually rated whether or not the letters of recommendation specifically cite cultural competence as a trait. We actually rate the candidate on whether or not they've participated in community outreach activities. We rate them on whether or not they've been exposed in a meaningful way to cultures other than their own. And we rate them on whether or not they have experience serving underserved or disadvantaged patient populations. So what would that look like if you made this a top priority when making your rank list? It would look like this. Each year, for 8 years in a row, at least one of our interventional cardiology fellows at The Ohio State University was an underrepresented minority. This is what it looks like when you truly believe that diversity enhances quality, because then you use tools that help you enhance diversity, because you're acting on that belief. So in summary, as you know, there's a global call to end systemic racism in all aspects of life. We have a role to play in medicine, whether it's private practice or academic medicine. We have a role to play. We have things that we can do to combat racism. In response to the events of 2020, medical centers made bold anti-racism statements. I'm here to say that the most powerful, the most durable anti-racism statement that we can make is to diversify our ranks. And so as I end here, I'm going to ask you if you remember the racial disparities in COVID care that was front and center. If you remember the murder of George Floyd, and as you know, it wasn't just the murder of George Floyd. In fact, we have 2 very high profile cases going on now of some other tragedies. I'm going to ask you to remember, did you take a knee? Did you have some kind of demonstration at your hospital? Did you pledge to do what you can do to fight discrimination or racism? So how's it going? This is your check-in. Thank you very much. Happy to take any comments or answer any questions.
Dr. Capers, thank you for that excellent lecture. I think Dr. Vidula and I are here, and others are here also. So anybody in the audience, if you have any questions, feel free to put them in the chat, or if you'd like to, we can bring you guys up if you would like to ask a question yourself. I can start us off. So, you know, you raised a lot of issues that I think we have to talk about, and people, it really makes people think. You know, we're all doctors. We've been dealing with this for a long time. Many of us sit on selection committees as well. Something struck me by what you said about the common gut check reaction that people have to this comment, to this whole idea of increasing diversity, is that in admissions, shouldn't we just do it the American way, which is get the brightest and the best, that whole meritocracy thing. And I think it's the question really becomes, do we take someone based on their individual metrics, or do we take someone because the combination of those individuals will better serve society? And I offer it that way to you because I think we've been a very individualistic, self-serving society in that the individual is always front and center, whereas we probably don't look at things as what's best for society. So can you touch upon those things? Because I think trying to tell people to change or to accept change means changing that belief system about why doctors are in society. Are we in here for ourselves, or are we in here for society?
Such a brilliant question, and I like the way you frame that. And you're right. We've got to change hearts, and we've got to change minds. And I like how you frame it about what's best for society. And so one way that I would pose it is, if you look at some of these healthcare disparities, which certainly anybody looking at them, I mean, they're heartbreaking. This is the result of doing it the way we've always done it, right? This is the result of choosing, of all of your applicants, the ones with the very highest grade point average, the ones with the very highest MCAT score, and not looking at anything else, or the very highest step 1 score. What has that gotten us? That has gotten us to a point where people, because of where they live, because of their race, because of how they look, don't get the same excellent quality of care. So why not try something different? And I want to be clear here, because sometimes people might get the impression that I'm anti standardized tests. I'm not. I think standardized tests are a good idea. If I were, for instance, the dean of an architecture school, and I had way more applicants than seats, and since math and physics are important in architecture, if there was a standardized test of math and physics, I would use that. I would use that in the application process. The point is, I wouldn't let that be the only thing that I'm using. I wouldn't let that outweigh everything else, which is essentially the way that we've been doing it. So I'm not anti-standardized tests. I like the MCAT. I'm a fan. I like step 1. I like step 2. I'm a fan of standardized tests. What I'm not a fan of is having standardized test results be the absolute bulk of the decision that we make.
Great. Dr. Vidula, Dr. Brown-Talaska, did you have any questions about the Capers? I have others if you don't.
I definitely do. Thank you, Dr. Capers, for being here today. I'm sorry I was late on the meeting, but I ran up from the ER. I heard about 75% of your essential talk. So I'm happy to meet you. Thank you for being here. I have a question that jumps off Dr. Naidu's statement. So with regard to the metrics, why, in your opinion, or what do you want us to look at in terms of the reason behind the rather emotional or aggressive response to the need for diversification in cardiology? When you get responses to the survey that I wrote down here, well, this should be a meritocracy. That implies that diversification of cardiology would not rely on merit anymore, right? And that would sort of dilute the intellectual integrity of cardiology and lower the bar. And I want to hear your opinion on why you think that is, why you think there's such an emotional attachment, or like almost a gut reaction to this word of diversification in cardiology, when it doesn't mean I am going to dilute the intellectual, currency. I'm not going to turn it from $100 bill to a 1 cent, commodity by diversifying this field. And I feel like that is the implication behind statements such as, why are we diversifying, right? We should rely on merit. Then that implies that we're not relying on merit.
Yep. So it's very nice to meet you too, and thank you for joining us. I love the question, and it's I could do another hour just on that question. And I think in this country, we still I think by and large have a problem dealing with the reality that if you consider it, let's say, a race, we use the analogy of a race with a starting line and a finish line, that everybody's not at the same starting line, that there is structural racism, structural barriers, discrimination in housing or where we're allowed to live, who's allowed to live in a neighborhood with the best schools versus the neighborhood with the worst schools, who's allowed to live in the neighborhoods with a nice clean air so they can be healthy and have good clean water versus the neighborhoods that aren't. How do we police people? How do we treat people when they're caught up in the system, et cetera, that makes it so that we're not all at the same starting line. And so if you at the finish line are only saying, we only care about the results you got on this test, then that is inherently unfair. That is only fair if everybody has access to the same after-school programs, to the same prep programs, to both parents being able to have a good job so they can be home and teach you how to read before you get to kindergarten. If you're in a society where all of that is even Steven, then it might make sense to say, listen, we're only going to go by your test score. But when you're in a society where there is discrimination that's baked in, such that people are starting at different points in lives, for you to say, well, the great equalizer is this test score, is just putting your head in the sand about the structural racism that we deal with. Because somebody, now let me tell you again, I'm a fan of standardized tests. So I'm not saying if you absolutely bomb a standardized test that we should take you just because it would be fair. No, you've got to have a certain amount of critical thinking and intellect. But what I am saying, I like to use the analogy of the driver's license test. You know, how many times have you been in a cab or an Uber or a Lyft, and maybe even you took a nap while your driver was taking you someplace? So you literally put your life in that person's hands. But I bet you didn't ask him or her what score they got on their driver's license test. You trust the fact that the DMV made a test that is pass fail, right? Our driver's license test pass fail. You trust the fact that they made a cut point that is a very good discriminator of who is good enough to be driving and who shouldn't be driving. So you didn't ask your driver, hey, did you get everything right on your driver's test? Or did you miss 2 or 3 questions? And if they missed 2 or 3 questions, but they passed, then that's okay for you to take a nap in the back while they're driving you on a busy New York street. And so it's the same thing, because people have different starting points. They might have missed a few more questions on the exam. That doesn't mean they're less deserving of an opportunity to be a doctor, because they're still good critical thinkers.
So my follow-up question to that, and I'm sorry, Dr. Bridwell, if I'm taking time from you, but in terms of the evidence, what evidence would you propose to folks to show the success of underrepresented racial and ethnic minorities in cardiology, to say, well, look at this data that shows that when they are given opportunity, they thrive?
There are tons of data from medical school, from residency, from fellowship, that people can be successful, and their success is not determined by those standardized tests. Now, standardized tests are really good at telling you how well you're going to do on your next standardized test. So from the SAT or ACT, that predicts how well you're going to do on the MCAT. And and if you think about your own self, you probably, I'll bet you that you got about the same percentile on your SAT as you did on the MCAT, as you did on step 1, because that is really what it predicts. But it doesn't predict how hard you're willing to work. It doesn't predict your compassion, and it doesn't predict your success as a physician. So I'd be happy to share that data with anybody that wants to hear it. I'm glad you're asking the question, because that's the point I made with how do we push back against the pushback. It's not passion. If we get too passionate and heated, then we're losing. But it's showing the data. The data's there, but the impetus is on all of us, though, to not rely on that data, but we need to always be working on more data, because data helps convince people. And so we've got enough, but let's get some more.
So on that, I think we're coming upon the hour, so I do want to thank you. There was one more question about implicit bias, but I think we can do, I've heard your talk on implicit bias. I think maybe we'll do another session with you in the near future about that, where you go through some examples. But with that, I do want to thank you. And again, for everybody who's listening in, we'll put this on the web in edited format, so you can learn this and share this around on social media, which is, I think we talked about that. Dr. Capers wants that as well. And finally, there's 1 hour CME, so please put all your information in when you get the email, so you can get that credit. Thank you also to our wonderful New York ACC staff for doing these presentations, and also to both you, Dr. Vidula and Dr. Brown-Tulaska. Thank you.
Thank you very much.